Warm welcome to you all, and thank you so much for this opportunity. Currently, I'm working as an assistant professor in the Department of Psychiatric Social Work, but I'm a consultant at a Center for Addiction Medicine. That's where the whole therapeutic engagement with patients, which we are doing. And I welcome you all to work in the area of addiction because it's very interesting. I have joined maybe around 2 years back. But however, it's so interesting that I think most of the social workers, psychiatric social workers, need is there in this field. So basically, before I go to this, addiction medicine is an important area, which is one of the major areas of mental health, and it also comes as public health issue, and it also is known as non-communicable disease. So it comes under various domains as an important problem or a problem that we all face in our society. So there are various types of substances that people use. The magnitude of substance use manual has depicted that children from the age of 10 onwards start using substances, and up to 75 people are using. So there are various stages and diagnostic guidelines for considering one as dependent or an addict. So there is something called as harmful use, then there is something called as hazardous use, then there is something called as people who have to go through that tolerance, withdrawal, and then they move on to addiction. So the patients who come to us with this particular problem, that addiction as a problem, is the people whom we apply this particular intervention. So basically, what we try to understand is from the psychosocial point of view, but however, there are some aspects of maybe your psychology class you may have to somewhere recollect with regard to motivation. So I will just brief on that. Basically, motivation is something which prompts us, it compels us, it energizes us to act or behave in a particular way at a particular time, to a particular situation, or to attain certain goal or a purpose. So that's something that has there within all of us. So it activates through these forces. One is needs, another is drive or a motive. So the activating forces of motivation comes under these categories. So needs is something that we all have, a desire. It can be a biological need or a psychosocial need. Biological need in the form of fundamental need for our survival and our existence, in the form of food, water, oxygen, sleep, etc. And psychosocial needs can be associated with our social, psychological, and cultural environment, which gives us a lot of boost and emphasis our living in a healthy way. So that may include security, love, affection, freedom. So these things are commonly that we understand in the context of a need. So drives is something which is little in an aroused reaction tendency or a state of heightened tension that sets up activities in an individual, and also it sustains them for increasing the general activity level. So it's something that pushes you. It drives, or it gives rise to a drive. So it can be in the form of hunger, thirst, sex, which are primary drives. Secondary drives may be an anxiety, and aggression, and dependence. Basically, these tendencies give us a chance to push ourselves into something or an activity level to do it in a more better way. So the next stage or next aspect is motives. If you have seen, drive is something which pushes us. The motive is something, it is an inner state of mind. So it is generated through basic needs or drives, but which compels an individual to respond till we achieve a goal. So it may be hunger motives makes us to work, hunger motives makes us to earn something, thirst, and sex motives makes us to get acknowledged by somebody, maternal motives makes us to marry and have a child, achievement motives makes us to study hard. So these all are certain inner state of mind which drives us to work through the basic needs so that we achieve these goals. So these are the three aspects of motivation. So there are various theories of motivation which has been studied across over a period of 2-3 or many decades. So we all have heard behaviorist point of view, which talks about need and drive reduction theory, that is push theory. Like if you want to get something, maybe a social learning theory also is partly associated with that, where you have if you to get something, you have to wait for something, and you have to push yourself so that you get into that particular achieve, or you achieve the goal. And you have to have a stimulation. It may be in external stimulation or internal stimulation through which you try to achieve that goal. So instinctive theory, as Freud says it, that you have to have an internal instinct which drives you to get into the particular to achieve something. And it can be sometimes in the form of what you deprived of, or something that you are looking forward to. So the instinct within you actually pushes you to get into that. Social urges theory Adler's point of view says the urge makes you to get into a particular goal, but sometimes the social urge can be in the context of something negative, so or something positive. So how that social urge derives, or how that social urge takes you through various paths, that will lead whether you will get into a healthy habit or unhealthy habit. Goal-oriented theory, mostly a cognitive point of view. Many have proposed this, where you have a goal, so you work towards that cognitively and constructively, so that you are able to achieve the goal. So you make various steps to achieve that goal. So when you have a goal-oriented motivation, your planning, your achievement are correlated. So self-actualization, we all know that every need we achieve, we want to get to the higher level. So every stage is after achieve that stage, you may move on to the next level, so until your self-actualization stage. So these are certain motivational theories which have informed us that yes, if your internal mind drives you, and if your internal mind takes you in the direction, and there is a stimulation for you to achieve, you will be able to reach. So in this context, where we have exposed to something called as motivational treatment approaches, it is basically designed to enhance patients' intrinsic motivation. As we said, based on these theories only, this which is understood that it is an internal aspect of an individual which needs to be helped by professionals like us to bring it out, so that it helps the patient to come out of the problem. So in the context of motivational treatment approaches, we have three different types of approaches. That is, one, brief motivational intervention, one is motivational interviewing, and motivational enhancement therapy. I would like to give emphasis on MI and MET, because BMI is something that we might do in our clinical postings, that is more or less of a psychoeducational level. So it vary in duration from 1 to 4 sessions, maybe during your OPD and in follow-ups, where you tend to give a straightforward advice and information on the negative consequences of alcohol abuse. Have anybody are associated with any posting in de-addiction as of now in your respective posting? Anybody have got? Somebody can mention in chat also, if not. Or you can unmute yourself and tell. Anybody working in the field of addiction, in the sense got a chance to get posted in addiction medicine? Chat.
Okay. There are no responses as yet on the chat.
Yeah, sure.
Okay.
Yeah. So generally, when you are seeing patient in the OPD, this is something that we all expected to do, that is an advice and information on the negative consequences of alcohol abuse or any for that matter substance abuse. So when it comes to motivational intervention, it's more adaptable in the area of alcohol abuse than many other substances. So that's why you would hear or you would see alcohol dependent patients, alcohol dependency. So these kind of statements you would see more in my PPT, because mostly applied to this clientele, and it has got good result from this system. So if you go for cannabis or opioids, there are many other intervention strategies that we use, like contingency management and matrix therapy and things like that. So for alcohol, people with alcohol use disorder, we mostly use MAT. So we also, this gives this is something where minimal motivational interventions that can be given, because lasts for 10 to 60 minutes. So you cannot give too much of, I mean, what we now going to study in MI, we will not be able to do in that detailed way. So relevant for problem drinkers who are not yet alcohol dependent. So maybe in the level of hazardous drinking, in the level of harmful drinking, or they are youngsters who are just getting into the mode of daily drinking. It helps them to come out of the problem through this brief motivational intervention. The main goal is to reduce drinking rather than abstinence. Again, now we have come to approach in the area of addiction medicine, that is the abstinence, if it is difficult to achieve, or if you are unable to be sober, or if you cannot stay away from alcohol, so reduce the quantity, reduce the drinking. So that is the kind of approach that we are trying to apply these days. So this helps in those kind of clientele. Now we are moving on to an important category, that is motivational interviewing. Please try to give little more emphasis to this. Very interesting, very important, and very feasible intervention. And it actually gives good results if we are able to understand. I mean, one of these sessions will not for sure be enough to understand this concept. I urge you all to read. There are a lot of literature available on internet, and Project Match itself has published a beautiful book on motivational interviewing and motivational enhancement therapy. I urge you all to read it in the future. But just to give a just to give a brief information, I'm just touching upon this. Basically, this particular concept of motivational interviewing was evolved from the experience in the treatment of problem drinkers, which while Mr. William R. Miller and Stephen Rolnick, when they studied these problem drinkers, and when they experienced the treatment was failing again and again, and some of the treatments, some of the intervention that they tried was not helping, though they were of the great assurance that after the patient is discharged from their hospital, he or she will be really picking up based on the information or the intervention they are given. But it all failed in the forthcoming days after their therapy. So they started exploring what are the kind of interventions. Like, it was always giving advice, I know and you hear from me, like what we do in our some of the therapeutic interventions. So these kind of interventions that were, because we all understand, I mean, there are a lot of myths and misconceptions with regard to alcohol or substance user, that it is character failure, it is their inability to control. If they try, they can control. And these kind of statements or misconceptions were forming. So because of that, it was always we give and you listen kind of story it used to happen. So in 1983, they published an article in Behavioral Psychotherapy why they have to change the concept of treating patients with alcohol use disorder. So they elaborated on this fundamental concepts. In 1991, it came more as a clinical procedure itself. So these are the two people. And they explain that it is a client-centered, directive method for enhancing intrinsic motivation to change by exploring and resolving ambivalence. So our main role, if you observe here, is just explore and resolve ambivalence. We are not talking about adherence. We are medicine adherence. We are not talking about treatment goals. We are not talking about abstinence. So this is what they come up with that technique. Basically, the basis for this was they used this model called PACE, that is partnership. As I was mentioning, avoid the expert role. So more of a partnership intervention that was highlighted here, and acceptance. As again, I was mentioning you, there is a fault in them. They are unable to control. If they can, they try to control. So this is the kind of thought process that would run in a clinician's mind. So, but here the PACE model says acceptance, respecting the person's autonomy, perspective, etc. So that helped actually to establish this into a therapeutic intervention. Then compassion, basically compassion, I don't have to explain. Evocation, the best ideas do come from clients. So we evoke those ideas so that the patient themselves share with us the ideas for their future goals. So with this model, the motivational interviewing took off. The core skills of motivational interviewing is these ORS, we call them: open-ended questions, affirmations, reflections, and summaries. Throughout MET and MI, you would hear this statements again and again, so that you will be affirmed, or you will be reconfirmed that these are the important techniques of MI or MET. So open-ended questions, I'm sure you all would know in maybe client-centered approach we sometimes use. So we do not ask them directly, tell me how much do you consume, or what is the quantity that you take in a day or in a week's time. So instead of talking or asking this kind of direct questions, generally in MI, the therapist will ask, what role does alcohol play in your life? Or how do you explain that, how alcohol is, why you like alcohol? So these kind of questions which gives a direct answer from them. If you observe, I consume to get sleep in the night, so I consume to reduce my body pain. So these kind of, so now you know that what is the precipitating factor. So then it becomes very easy for you work through that problem. So I'm not saying it is that easy, but this is the only way they feel that we are compassionate and we are not asking anything derogatory towards the clients. So affirmation, some of the examples, basically some kind of positive statement that creates a sense of self-confidence. So it gives them a chance to answer the query that we ask. So that we also give a positive statement where they don't feel that, okay, I'm a patient and they are questioning me. So that kind of environment is not created. Despite all the problems, you have been doing quite well at work. So this is the kind of affirmation statement that we can give. So the client feels that, yes, doctor, it is tough to balance, but I try to manage. So there is nowhere you are pinpointing or finding out that the client has not gone for work, client has lost the job. So there is nothing of that sort. So it's like how client with, maybe acquaintance would talk. So that kind of feeling the client gets here. So reflections are another principle in which the understanding of what client or patient is thinking and feeling and saying it back to the person to convey empathy or understanding. So we do a lot in these kind of techniques in our counseling sessions, where we reflect what client wants to say, and we also confirm whether what he meant and what we meant are same. So this gives us the client as well as us an understanding that we both are in the same pace. So this is another important motivational interviewing method that we use. And then summary, it is basically collection of more than one reflection. So so far what all we have understood, that regarding alcohol, this is your thought process. Regarding your plan for visiting hospital, that's you want to do this. So this is the, and then we keep reflecting on that, whether what you have said is correct, and if the client wants to add anything more. So this is how it goes. So you don't see any therapy happening here, rather it is a kind of interview. It is a kind of questions that you ask that itself reflects the client. Oh, I think I can understand what they're trying to say. So that is the kind of feeling the clients get. So process of motivational interviewing, basically the process goes like this: we focus, then we engage, again we evoke, and then we plan for an intervention. That will be MET. So engaging is a process of establishing a trusting and mutually respectful relationship. A therapeutic relationship or therapeutic alliance is built through MI. So that it helps the client to feel that they are part of the, they are equal, they are in the equal partnership. So there is no assessment here, so we avoid assessment. Then there is no labeling, like, okay, this is the unit that you are drinking. So if you drink the unit, and if you start in the morning and you have tremors in your hand, so that means you are dependent. So none of these labelings will be observed in MI. Then the next process is focusing. So in the context of our therapeutic, building the therapeutic relationship, we try to focus on what kind of goals they want. For example, some of us, when we start our MI, we ask them, so what is the reason for you to come to hospital? What best can we help you? So it is a setting an agenda for change. They will come and tell me that, yeah, I have interest in stopping alcohol, but I would like to continue with my smoking. So then the focus is, we have got a direction. So then we have to work towards maintaining that direction. So that is the focus we get through MI. So this allows us to set an agenda for change. Then evoking, it helps in eliciting the client's own motivation for change while evoking hope and confidence. So we keep so there is something called as change talk. I will be explaining change stages of change later. So basically, why do you want to have make the change in your life, and what is your first step towards that? So this is the kind of method we elicit the motivation level of the client. So it basically helps us to know where exactly the client stands, whether he has interest to stop, he has interest to reduce, or he has no interest to stop at all. He has come by force of the family members, or somebody, maybe lecturers in the college, or girlfriend, or the spouse. So this idea we get when we try to elicit the motivation for change by the client. So according to this evoking of client's motivation, we start planning. So the planning involves the clients making a commitment to change. So whether they are the stages of change, when I'm talking, if they are in a stage where they did not want to stop alcohol, then through our interviewing, and or maybe by being in the hospital, and know that when we give a lot of feedback about their health status, they are getting into a commitment to change. So then the next step can be planning with the counselor and the client together, and develop specific plan of action. So basically the planning should be comfortable enough to achieve. So we should not make plans which is not achievable, and client also loses interest in our intervention. So it should always be specific, measurable, and achievable plan. So this is the skill that we have to have when we do MI. For all therapists, this is the kind of spirit of MI, we call this. So collaboration, we collaborate with the client. We do not, we are not here as therapists, but rather we collaborate with them. We go with the goal that is discussed together as a team. Then autonomy, client has full autonomy, client should be given full autonomy. So that also gives you a kind of feedback that you also can extend your autonomy. Like, see, this is something that I did not expect that you would do after you go after our session. Maybe I thought you would have tried to apply certain skills that I taught you. So this is a kind of autonomy that can be developed, so which can help client to recollect or retrospect and see what he could have done better. So this is the kind of autonomy that is important between the client and the therapist. Then evocation, as we said, this evocation is basically the client's perspective towards the problem, not therapist perspective towards the problem. Then compassion, which with these foundation, actually MI is built. And the principles of MI is, of course, again and again, as I said, reiterating the certain statements. That is part of MI and MET. So partnership is one of the key principles. Then acceptance, we have understood this. Compassion, we have understood. Evocation. So these are the key principles of MI. So finally, motivational interviewing is something which in supervision maximizes focus and positive change by developing action plans and addressing ambivalence towards change. So the client, when he or she came to the hospital or OPD or a de-addiction center, was in the context or was not at all planning to quit alcohol or reduce, but there is we at least take him to the level of ambivalence. Should I change? Should I actually try stopping? Should I actually try avoiding friends? So these kind of contemplation we can bring in the mind of the client through motivational interviewing. So we are always there as supervisor, as in supervising them, so that they maximize their focus. For this, actually, there is something called as frames, which helps us. It is an interviewing guide, which helps us to take them through this process. So as I said, it goes on to 4 sessions. So whatever we have spoken so far goes into 4 sessions. So the initial sessions itself, we apply this particular guide. That is frames is an acronym for feedback, responsibility, advice, menu of options, empathy, and self-efficacy. So we apply, I think this, if I go too deep into that, then I may not be able to finish the another aspect, that is MET. To give you a brief understanding, this we call also as brief intervention method. So in this brief intervention method, we give the feedback to the client about their health status. We give the client the information that we got through their medical investigations or through the information that we collected from their supervisors or family members. So this is the kind of feedback we give, which actually makes the client think whether he or she wants to get into the mode of therapy or motivational interviewing, whether he or she wants to get into. Then responsibility. What is the kind of responsibility client would like to take in the process of this interviewing or in the therapy? Whether he or she would like to listen to us and apply that, or it is just that he or she wants to just share and ventilate and feel free for having done this, or whether he has committed anything that he wants to take responsibility, or he wants to take the responsibility of staying abstinent, so or continuing treatment. So this kind of evoking various responses we try to do through this method. Then advice is basically not the typical advice, you do that, you do this, not that. Advice is whether they are going, when they are taking responsibility, whether that responsibility has a better better response, or whether that has a better result, or it can have a other implication. So this is the kind of advice we try to give them, so that they can change their plan of action. So then menu of option. There are various techniques that they can use to handle their alcohol craving, then cue management, or various problems, interpersonal problems, or peer pressure, or handling other issues in the society. So we give menu of options, or the client themselves will give menu of option. For this, what you can do, for this problem, what you can do. So we discuss menu of options, which can be applied first, which can be applied at a later stage. So this is the kind of discussion we have. Empathy is something that is all of us know that any client who comes to us, we should provide. So that same empathy ground is applied here also. Self-efficacy. So by doing all this, what is the client's client would like to achieve? So anything that client says becomes his or her decision. So it is no, we don't force any decision. So they are capable enough of handling what they have informed us. So we give all the responsibility to them so that they apply this method and they come up, or they come out of the problem in a better way. So with this guidelines, we then go to the motivational interviewing, wherein after, this is all goes throughout the MI sessions. It's not that we finish all this and then start MI, but they go hand in hand. Wherever possible, these guides will give us an idea where exactly we have to apply this. Maybe in the second session itself, client says that I'm helpless, I don't know what to do in this kind of situation. Then we might immediately come with menu of options. So it can go little not in the same order. It can be maybe client can first come with self-efficacy, that I would like to do that, help me. So then medication, intervention, so all that can come into place. So the self-efficacy is high with the client who comes with this kind of motivation. So this is the something that we do. So now I'm moving on to motivational enhancement therapy. So far, whatever I have said, if you have any questions, maybe I give you 2 minutes time if you want to ask any questions. Otherwise, we can take at the end of the session. I have just kept the chat box open if anybody wants to. Ma'am, in substance cases for psychosocial management, therapeutic alliance will always be after MI. Not necessarily. So therapeutic alliance can be one of the major, what do I say, major aim of MI. So it not necessarily be, so the therapeutic alliance builds over MI. It doesn't start, we start the therapeutic alliance, then start MI. See, for example, the client is referred to us in the OPD. So immediately we do not take, not in MI, basically, we're not supposed to take case history, then collect all the information. So MI starts when they come with a problem and where they are given an open space to share. So the first step itself is to have an open-ended question. So as I said, ORS to apply so that the therapeutic alliance builds. So ma'am, do frame or brief interventions only for dependents of short? No, it can be applied to anybody. It can be applied to people who are there in the maybe those who have got 8 years, 10 years, or whatever the duration of illness. Basically, it wouldn't have applied before. Like you cannot apply frame at every things every time they come. So then you have frames applied, then you have MI done on them, then you have MET is been applied on them, then you do relapse prevention, then you may need to do some other behavioral intervention. So it goes on like that. So not necessarily for the people with short duration. Thank you. I think, yeah, thanks. So moving on to MET. So this is first, one second, yeah. This is first developed as a project, actually, project matching alcoholism treatment to client heterogeneity, which began in 1989 in the USA, which was sponsored by National Institute on Alcohol Abuse and Alcoholism, NIAA. This project run across 8 years in multi-site investigation sites, which studied what are the best treatment options for the people who respond best to the intervention. So there are 3 interventions they have highlighted. Over a period of time, they have studied what all the various treatments been applied to the client. So among that, 3 major intervention programs they have selected. One is cognitive behavioral coping skill therapy, and another one is MET, and then another one is 12-step facilitation therapy. So 12-step facilitation therapy is more connected with Alcohol Anonymous groups because it has come from that big book. So they adapted little different therapeutic intervention. So one of the major treatment options they selected was MET. And to give you anyway, it's here only. The study concluded that patient treatment matching is not necessary in alcoholism treatment because the three techniques are equally effective. So end of the session, end of the study, they did not prove which is better, but all has an equal effectiveness is what something they studied. So later also we continue to do this intervention, but motivational enhancement therapy was I mean, basically it used in the context of I mean, for example, it's a time limited, time bound intervention with 4 sessions which adapts motivational interviewing. Then another 4 session goes into motivational therapy. The goal of the therapy is not to guide the patient. Again, the extension of MI, it is not to guide the patient through the recovery process, but invoke inwardly motivated change. So more of internalizing the problem and more of internalizing the solution for the problem to the by the client. So it focuses on treatment of alcohol and other substance addictions also, but more so with alcohol. All, like for example, cannabis dependency or opioid dependency, as a matter of fact, because it talks about any drug use, because deviation from the normal routine can be re-established through motivational enhancement therapy. That way other substance also is used, but more and more studies, research, and the better result was found with, especially with the people with alcohol use disorder. So, but it doesn't mean that other substances also it cannot be used. It can be used. So basic principles, we call this as DARES or EDARES if you go by the order. Again, the principles are little developed from MI, but it also has little more expansion. That is, we all know that expressing empathy is the first step. So first principle in any intervention, so is with MET. Then develop discrepancy. So this is very interesting intervention mode, like how we, when we do MET, like you try to make the client identify the difference between what they are and where they want to be. Like what is it currently they are in and where they want to see themselves, maybe in the timeline that you and client decide together. So you develop a discrepancy between the existing system and the goal they have. So that gives a wide opening or idea to the client that, oh my God, where I am standing now, and actually to reach that goal, what all the things I have to do. So this kind of notion gets developed in the client's mind. Then avoid argument. In for example, today there was a client who is our own security guard who has lost job and he has come. So we told him that I mean, he was insisting on discharge. So this is the second admission. So he told, I can manage by myself. So you can discharge me and see if you can, if I'm doing well or not. Only thing what I need is I need the job which I lost. If you get me that job, I'll be able to do better. So we were trying to explain that you lost the job because there was behavioral issues post your alcohol use. So that was the reason, but we could not, we should not argue with them. So we were asking him what has not worked after you left from here. So where was the problem? No, I'm losing the job. So then again, we have to come back. Why did you lose the job? So again, he was not in a position to say that I have taken alcohol, that is why I lost the job. He kept on saying that I don't have family. I mean, my family is broken because of my alcohol. So I want to get my family back. I want to get my job back. So I would like to take treatment, but discharge me. So only thing what we could give is give a feedback saying that your health status is requires some more days of intervention and treatment. So once you achieve that and your health is stabilized in the form of blood investigations, in the form of nutrition, in the form of adequate sleep without the help of alcohol or medicine, then I think, are you good to go? Then he said, yeah, that I need actually. So then we came to an discussion that, okay, as long as all these things being achieved, I am to stay here. So there was no reason for, I mean, there was all possibility for an argument. Ray, you have done this, that is why you lost job. You have done this, that's why your wife has left you. So, but there is no point in doing that. Even in our regular OPD or IP care also, this has gone so much into us that we do not argue much with the clients, which, because it doesn't give, that again brings a kind of therapy, I mean, gap between client and us. So avoid argument is another important principle. Then rolling with resistance, as this is another important aspect. So that you might find clients not being accepting what you're saying. So we keep rolling with their resistance only. We do not confront, we do not say that what you're doing is not right, but we keep moving on with their resistance. So we give them a chance to resist, we give them a chance to come up with maybe some hasty decisions. Then we ask them the benefits of doing that, or what can be other ways to look at it. So this kind of techniques this kind of idea with which we talk to them, so they understand that how much can they elastify that discussion. So somewhere there will be a common understanding that, okay, hence now I come back to the point that, okay, I have to work towards, internally I have to work towards handling my craving or something. So this is the kind of idea that we have when we use this particular principle, roll with resistance. So support self-efficacy, as I was explaining. So the client can accomplish the particular task by their own capacity. So the client has to be persuaded that the drinking somewhere it is possible to change their own drinking pattern, thereby reduce related problems. So this accomplishment, to go to this accomplishment, what all the way they have to work backward to achieve that. So this is the kind of orientation, this is the kind of idea we have. At the end of it, we would like to achieve, but for that we keep asking certain questions that will lead to the self-efficacy. There are different phases. One is to build the motivation. Another is to strengthen the commitment to change. Then follow through certain strategies. I'm explaining that, but the slides are a little bit clumsy. Hopefully, I'll be able to make sense. Before going into this particular phase, like building motivation for change, we need to understand what is this motivation for change. I kept on saying there is change talk, there is change model, there is a stage of change. So I kept on saying this. So I request all of you to just give a little more focus on this part, because if you know this, you know at least 1/4 of, or maybe 30% of MI. This MET. So basically, MET was developed based on this trans-theoretical model of change, which was developed by James O. Prochaska and Carlo D. Clement. They proposed 5 stages of motivation. It is not, if we reflect, we can reflect in the context of alcohol, but if we reflect on our own selves, we also can reflect with our own day-to-day limitations or day-to-day things where we would like to change. So it basically proposed in the year of 1980s through trans-theoretical model. Basically, each individual has the tendency to develop different habits. So when they develop different habits, sometimes we are stuck without changing that. We do not think of any alternative, why the change was not made. So this is when they have identified that helping them to successfully come out from one stage to another, come out from one that stage to the next stage, helps in a lot of their behaviors. So some of the complex health behaviors like smoking, smoking or alcohol. So in all these context, it can be helped. So it is proven successful with wide variety of simple and complex health behaviors such as smoking cessation, weight control, sunscreen use, so reduction of dietary fat, exercise acquisition, quitting cocaine, mammography screening, and condom use. So it is not restricted to only, as I said, only alcohol or drugs, but for any individual who have lack of motivation, we can assess ourselves where exactly we are. So then it gives us an idea why we should go for next level. So the stages of change, what they explain is in is in as a 5-stage that we understand, or we generally talk as stages of change. That is pre-contemplation, contemplation, preparation, action, and maintenance. So sometimes when the spiral can reverse them back to a relapse, or it can also go to a side where you have recovery. So recovery or relapse are an optional, because when the stages of change failed, where the spiral has come back, if you see the arrow, if the spiral has come back, then again you will come back to this stage. So if the relapse happens, then you come back to this stage. So if from maintenance, sometimes you can go to the recovery path, which is more successful path. So what happens in each stage? So generally when the person with alcohol use disorder or substance use disorder, and this is applicable to all kinds of, even gambling, even any behavioral addiction. So in any of these problems, we can identify or we can observe these stages, or we can assess them based on these stages. So it gives us an understanding, how do we use MET or MI for this client. So if they are in what generally theories or the studies say is, when client is in pre-contemplation stage, it is a bit difficult to convince them through MET. So if they are in maybe possibility of brief motivational intervention that I was discussing, that kind sometimes, or through frames, brief intervention, sometimes we can convince them to come to the contemplation stage. But what more successfully works when the MET works more successfully is when contemplation, preparation, or action stage. So we have more therapeutic alliance built, more confidence that we see in the client. So that helps us to achieve the goals faster and or in a better way. So what happens in pre-contemplation stage? The client has no intention to change the behavior. So what we generally observe is the client comes to us, to the hospital or a clinic or a treatment center. If the client has been brought by somebody, if the client has been forced, if the client is blackmailed, if the client has come in an altered sensorium stage, then there is you might observe the client being in this stage because he or she has not come with his own motivation. So generally it is because of the pressure of somebody else, or because of the pressure of something else. It may be withdrawal problems, it may be delirium tremens, it may be seizures, complicated withdrawal stage. So these are the things which would have made the client to come to us. So still you would find that they wouldn't give any importance that, yes, alcohol has made, or this drugs has made me to be like this, so my health has gone for a toss because of this. So they won't be in that understanding. So no intention on changing behavior, what we would see in pre-contemplation stage. So the contemplation is stage something where they are aware of the problem, and they know that yes, problem exists, but with no commitment. They have no commitment how they can change. Here we can actually work with client. So there is no commitment to any action. They don't know how to go about it, or they have no plans to go about it. They don't have a direction. So actually here, if we work, we can provide them a direction. We can build that alliance so that he or she can go to the stage of preparation. So again, a menu of options can be given for them how they want to go to a preparation stage. So contemplation is something where they are aware of the problem, but they have not taken any action towards achieving that. So preparation stage is somewhere client has given a thought about the problem, and they have an intention on taking an action. So thereby the problem can be addressed. So they have made some preparation. They may come up with plans. They may come up with some ideas how to go about it, but still they are not in action stage where they have applied the active action. They are in thinking level. Okay, this can be done, that can be done. If the peer pressure is that this is how I avoid, how do I avoid wine store, how do I avoid evening time, how do I, so these all there in cognitive level, they are preparing themselves. So this stage is actually helpful to us to work with the client in a little more systematic way. So action is something where they are applying action for the modification. It may be in the form of treatment, it may be in the form of handling the craving, it may be in the form of many other problems, health problems they go through, or they want to enhance their dietary pattern. So all these things can be observed as an action plan. So then maintenance is something where they have planned the action, right? And they have applied the mode of change. So that is sustained. So they see new and new behavior being replaced with the old faulty mechanisms. So poor coping has been replaced with healthy coping patterns. So all these things we would see as a maintenance factor. But when the maintenance factor is going on very well, we can't think that, okay, this is the end of it. So client is absolutely fine. Anytime client may go back to relapse stage where they fall back to the old pattern of behavior. And if the client is in maintenance stage and there is a possibility of the client, as I was saying, going to the recovery phase and improving and completely staying abstinent. So even if client has achieved this, we are not very sure whether the client will be coming back to relapse stage or client will be going to the recovery stage. So we will always have to maintain a relationship. We will always have to do the follow-up with the client so that the maintenance stage remains. It may be for 6 months, 1 year. To give an example, when a client who came after COVID, he came to us when he was 52 years. It was a relapse. So he then when the junior resident was interviewing, he said, I have come long back to the hospital when I was 26 years old. So that time we had general psychiatry ward where de-addiction was also treated. So he had come, taken treatment and stayed abstinent. At the age of 52, after the COVID, when everywhere the wine shops got opened, suddenly a thought came to him. Do I have the ability to control? I have been controlling for all these years. Will I be able to continue this? Or if I take one time, what will be the situation? He wanted to experiment. Many a times, this is what people come and say when they relapse, that I have left for 2 years, I have left for 1.5 years. Just I thought, okay, I have achieved. So they stop medication, they stop all the new behavior that we have educated them or they have identified. So all that comes back to a status quo. So that is when they take another drink. So that is when the reward pathways in the brain triggers whatever the old stage, old phase they were drinking. The person can go to the same stage within no time. So there is no time span that the patient will take this long time to go back to that. Nothing. Within days, within weeks, patient can go back to the old stage. So this man has gone to, within 15 days, he has gone to the level even much more than what he was in when he was 26 years old. So even after 20 years, this who was in a maintenance stage had relapsed. So we really cannot say when the client can be doing that. I mean, this going back to relapse. So this is basically stages of change. Hope I'm able to make some sense. If you have any questions with regard to each stage, you can ask me. So some of the phases, how we build motivation. So again, this is the same statements that I have told. We start with open-ended questions, elicit self-motivational statements. So some of the examples are, tell me what concerns you about your drinking. Tell me why you think you might need to make a change. So very open-ended so that client gets an idea. So this is the some of these motivational interviewing may be reflected here, but the end phase will be intervention. So this will be geared towards that. So after motivational interviewing, the client would have already gotten used to the kind of answer he or she has to give. So it becomes easy for us to go with the therapeutic mode to elicit the change. So tell me why you think you might need a change. So then this process is rolling. Some of the reflective listening is used, so that they keep telling what else, so that you elicit information which then we have to go to the stage. I mean, we have to use the techniques such as empathetic reflection, affirmation, or reframing. So the first MAT session should always include feedback to the client from the assessment. So this is done in a structured way, providing client with a written report of their results. So as I was telling in the frames, whatever that F stands for, that is feedback given. So generally provide the client a written report. So there should be very black and white information. So we give this a very structured way, because very much fact that we have to share them, no making them fearful, no intention of degrading them. It is just what they have got from their investigations. It may be related to liver, it may be related to their blood level, it may be related to their hepatitis status, anything. So this personal feedback report is very, very important. Again, this has to be given exclusively to the client, not to the whole family, not to all the members concerned. So it is exclusively his prerogative to have and known only to him. So when we do intervention with the family, so we deal with them in a different way, but for us here, emphasis is on the client. So many a times when we are doing the assessment, the client would have said, I'm taking only 30 units, or I'm taking only 3 units, I'm taking only 8 units, 12 units. But actually the report would give us a gross disturbance that have happened in the investigation, our gross report that has come. So then when we ask clients, there is a discrepancy, then the client will be able to acknowledge, yeah, I was taking more than that. I was scared to share because my wife was sitting, so I didn't tell fully. So this is the kind of reactions, response they give sometimes. And in the case of anybody benzodiazepine dependents or opioid dependents, again, they do not give the clear-cut information of all the substances there, all the varieties they are taking. They may be taking prescription drugs, they may be taking some other opioid-based drugs. So when we have the urine report or blood investigation report, and when we say that, see, you are positive for many things, would you like to tell more on this? Then they sometimes acknowledge, yeah, I was taking that, I was taking MDMA, I was taking LSD. So this is the kind of response they give. So because our toxicology lab can give this, separate report for each of the problems, because we can understand by seeing the client's investigation report, by seeing the client's eyes for opioids or cannabis, their body, their nutritional value. So this gives us a feedback as to where exactly client stands. So this helps us to give a very black and white feedback to the client in a structured way. Then we then go with the affirmative statements, which also includes, which seeks opportunities to affirm, compliment, and reinforce the client sincerely. I think it is great that you are very strong. You are strong enough to recognize the risk here, and that you want to do something before it gets more serious. So this is the kind of affirmative statement that we give. So then you really have some good ideas how you want to change. So this is the kind of compliment that we can provide. So I'll come back to that question. So this is the kind of affirmative statements that can help the client to, or it may sometimes reinforce them to open up. So reframing, it is a strategy whereby therapist invites client to examine their perceptions in a new light or a recognized form. So all these while people would have said, you are bad, you don't know, you are a failure, you can't control, so you are ruthless, you don't know what you're doing, you are you cheat, you lie. So this is the kind of statements they would have heard. But when we talk to the client, we examine their perception in a new light. And we recognize that, and we do not deny or we do not confront them. For example, if the person drinks after work, saying you may have a need to reward yourself for successfully handling the stressful situation in the job, which implies to say that there are alternative ways of rewarding yourself, but you have gone to a poor coping way to, or you have gone on a binge. So this is the kind of reframing sentence, which might sometimes look little overboard, but the client at that moment would like to listen more of an affirmative statements and reframe it in a positive way than critical comments, which he or she has been hearing all through. So that is the kind of change that we would like to bring through this MET. Then summarizing it also in the first sessions itself, the summarization of all the feedback given, affirmations that the client and we had. So we can do that after each session. So summarize can also happen periodically. So generally end of the session, it is especially useful to repeat and summarize the client's self-motivational statements. So all the statements he or she has told can be reiterated in the summarizing session. Elements of reluctance or resistance may be included in the summary to prevent a negating reaction from the client. So examples of a short summary. So thus far, you have told me that you are concerned. I mean, you are concerned you may be damaging your health by drinking too much, and that sometimes you may not be as good a parent to your children as you would like to be because of your drinking. So if the statement is kind of reaction what client has said, but we are putting it in a more positive way. So I think summarizing, paraphrasing and all, we have been hearing in the context of counseling skills also, but very specific to their behavior, very specific to their process of drinking, very specific to their life events, you have to quote here. No beating around the bush, no going way far beyond than what he or she told. It should be exactly matching with the statement, and we can actually reframe it or confirm it from them whether we have told it in this way that they have understood or they wanted to hear. So then discussion plan can happen. So the therapist may signal in a transition, well, what do you make of all this? What are you thinking you will do about it? What does this leave you in terms of your drinking? What is your plan? So this kind of discussion plans can happen, which can build the motivation for the client. Remind the patient of his free choice by saying it is up to you what you want to do about it. I am not pressurizing or forcing as to what you want to do. If you want a suggestion, I can give an advice, but I cannot decide for you. So the discussion plan will always have the client at the end of the thing saying what he or she wants to do. So it is a useful strategy. I mean, a useful strategy is to ask the client to anticipate the result if the client continues to drink as before. What would be the likely consequences? So these kind of things can be checked with them from time to time. The change plan worksheet also can be used, which will come in the phase 2. So this will be more focusing on how to strengthen the commitment. So far he has told that, okay, this is the plan I have. So we also are reiterating his plan. So now what is the actually change can happen through this session, where some of the strategies are outlined. And so in this stage, to consolidate the client's commitment to change, once sufficient motivation is present, this is by recognizing the change readiness. So readiness to change is something that we more emphasize here. So when there is a change readiness, how do we recognize that? There are some changes that we might observe. The clients stop resisting, then he or she will not have any objections when we discuss. Then he or she may look little resolved and unburdened or peaceful. So he or she may make some self-motivational statements. I guess I need to do something about my drinking. I want to change my drinking. What could I do? So these kind of opening up can happen in the change plan. So then we move on to the planning a worksheet. So then it can be wherever possible, we actually have a worksheet in our hospital so that the client makes the plan. So it also has cost benefit analysis, what actually helped the client when he or she drank, what actually did not help. So what was the benefit of change, like what is the benefit of drinking, what is the cost of drinking, what is the benefit of quitting, what is the cost of quitting. So this is the kind of plan worksheet that we give to the client. Okay, the change threes somewhere they have gone to the I think I missed that part. Sorry. But in the change three, phase three, what generally happens is they are into the practice of changing. They are into the practice of applying these suggestions, and they come when they have a limitation, when they have a challenge. Then again, we work towards that challenge, how they have to work. It's more of action plan. So then the whole MET can finish in 3 to 4 sessions. The 3 phases also can be done in each session. And if a certain phase is not completed in one session, it can be carried over to the next session. So each session is concluded with summary, and summary may be recapped in the next session. And then end of their 4 sessions, generally they are fully into the field, they are fully into the community to work towards their plan of action. So this is what we try to do in MET. Actually, I am rushing, I think. Thank you so much for your active listening.